Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Linda Farkas.
Thank you, Mandy. Can you hear me in the back? Can you all? Okay. So some of this may be a little redundant, but I'm hoping that you'll catch the pattern. So I was born in Pennsylvania, home of the Pittsburgh Steelers, right? And then I moved to Arizona, but they did not have a professional team there. But then, as Mandy said, I then did all my training in Chicago. And if you might remember, back at that time in the 90s, the Bulls and also the Chicago Bears were very formidable and won lots of championships. Well, then I moved back to Pittsburgh and was at the University of Pittsburgh for 10 years. And Steelers, once again, kind of came back and rallied, along with the Pittsburgh Penguins. So now that I'm here in North Carolina, maybe the Panthers and the Hurricanes might do something, right? Let's hope. So many times when I'm in the office, people always want to ask me, sorry, I'm moving away. Why the heck would you want to be a colorectal surgeon? And so basically, you know, it's a nice specialty where you get to do bigger operations, cancer operations, but also take care of some of the more minor diseases, but yet are very important to the patient. And so I think as a colorectal surgeon, we get to know our patients better than the average general surgeon. Our emergency patients tend to be the patients we know already. And, you know, starting out as a 30-some-year-old female surgeon, you have to find a niche. And colorectal surgery became a good niche because back at the time when I did my fellowship, there weren't even 50 board-certified colorectal surgeons that were women at that time. So a lot of this kind of brought me around to why I became a colorectal surgeon. But tonight what we're going to focus on is hereditary colorectal cancer. And so by the end, to get an idea of who is at risk, how do we test those people, how do we follow them differently than the average person, and how do we treat those who are at risk. So briefly, just a little anatomy lesson first in regards to when we eat our food. It goes down the esophagus into the stomach, and then just kind of wiggles all the way around through the small intestines before it lands into the colon. So this part of the colon is the right colon. It's on your right side. And as it goes up and crosses the abdomen, that's the transverse colon. And then the left colon, also the descending colon, the sigmoid, rectum, and then anus. So we're going to be focusing a lot on this colon here, but we'll also be talking a little bit about stomach and small bowel. So when it comes to colorectal cancer, if you look in regards to the risk of death for men, it's ranked number 3. For women, it's also ranked number 3. But if you look at it in combining the men and women together, right, now you're talking about colorectal cancer is number 2. And because breast and prostate can only usually share either the female sex or the male sex, and lung cancer is still number 1. Colorectal cancer, as I'm going to tell you about, is one of those cancers that can be very, very preventable. And we can find things before they become a cancer and treat them before they become a cancer. But we are diagnosing close to 150,000 people a year with colorectal cancer, and many of them can be preventable. And so basically, what are the risk factors? We know as we get older, we have a higher risk of cancer. Being overweight is not good. Smoking is not good. But then there's this genetic component that no matter how thin you are, how much you exercise, you never smoke, these factors can make a big difference in regards to your risk of colorectal cancer. And these are kind of the more obvious ones that we're going to talk about. And there are also some other pre-existing personal issues with the individual or patient, such as inflammatory bowel disease increases the risk of colorectal cancer. People who received radiation, whether it's for prostate cancer or cervical cancer, have an increased risk and therefore have to be watched a little bit more closely. Obviously, if you have had polyps or if you have had cancer, that certainly puts you at risk for increased polyps or cancers. So if you look at all the cancers all together as one big pie, the great majority of them are sporadic. We don't know why it happens, but something environmental within the individual. But then there's another about 30% that we can see there's a pattern within the family. At this time in 1990, when this pie was put together, we only had a few smattering of diseases that we could actually isolate where the mutation was. Now we're starting to chop up that pie a little bit more. And there's a lot of diseases we can give names to, and more importantly, because we can actually find the mutation when we do gene testing for individuals. So when we look at the incidence of colorectal cancer in the United States, you can see there is a colorectal cancer belt. It kind of follows the Rust Belt, as you can see this. Now, some of it does follow that some of these states aren't as good and compliant with their colorectal screening. Some of it may be environmental, or it may be depending on their ethnicity and the type of foods they like to enjoy. But some of it may even be a bit hereditary. And so you can see North Carolina is not quite so high, but where I trained in Illinois and Pennsylvania, a much higher incidence. And so when we look at the 142,000 people a year who are diagnosed with colorectal cancer, about 30,000 of them, we can see a family pattern. It's not real strong, but we can see a family pattern. And about 4,000 a year have Lynch syndrome, which I'm going to talk about. Again, within even North Carolina, we start looking at some of the counties. Some counties, like the ones in red, have a much higher incidence of colorectal cancer than some other areas. Again, part of it's probably compliance, part of it may be hereditary environmental. If we look at pretty much the counties that surround Wake County, we can expect that there will be about 682 colorectal cancers diagnosed. Now, we have gotten better. There's been a lot of PR out with Katie Couric and with Dr. Oz pushing the fact that you have to get your scopes. But, even as recent as 2005, if you look at those people who get ever a colonoscopy, ever a proctoscopy, which is not appropriate for screening, or ever get a fecal occult card, it doesn't mean they're getting it yearly, they just ever got one, we're talking only about 63% are actually doing it just a little bit, let alone doing it right. And again, you can see North Carolina is above average, but you can see the great majority of the United States is well below average on what we should be doing. So it's through things like this that we're trying to promote the correct way to do your screening and surveillance. So if the average risk person is not even screened correctly, I can only imagine if we would ask the question to someone, did you have a brother with colorectal cancer? And they'll say yes. And I'm waiting till 50 for my colonoscopy. That's the wrong answer. And so we're going to go through that. So the higher risk patients aren't even being screened or surveyed correctly. And some of it is because the public doesn't know, the patient doesn't know. If the patient doesn't care, I can't do much about that. But sometimes it's even the physicians don't know. And so it takes sometimes education of yourself as a patient to educate your own physicians. And so we can see that colorectal cancer, which is this white line, it is decreasing because we are getting better. So we can interact with our patients, we can interact with our families, and by getting them into getting their colonoscopies at the right time and the right intervals, we can impact who's going to get colorectal cancer. So when we look at stages of cancer, stage 1 is pretty good. I mean, most people are cured of their cancer. But as we get down to stage 4, these are people that have cancer that has spread to their liver or to their lungs. We can prolong their life, but it's pretty rare that we can cure them of their cancer. Stage 3 will require chemotherapy. And you can see that over 50% of the people are going to be stage 3 or 4. Our goal is what we want to do is make this such that we have more patients, stage 1 and 2, in the earlier stages. They may still require surgery, but they will not require chemotherapy, and we have a much better chance of cure. So, for the average risk person, this is someone who has no risk factors, no family history. They're not bleeding, they have no abdominal pain, they're not anemic, they don't have Crohn's, they don't have UC, they never had radiation. There's a whole kitchen load of ways that you can get your screening done. Even if you get a fecal occult card done every year, that's acceptable. I would complement it maybe with a sigmoidoscope every 5 years just to make sure you're not missing something, because polyps don't bleed every day, and they may not be bleeding the day you do your fecal occult card test. So that's not real perfect. So I would complement the two of them together. If you get a barium enema, which is that radiology test where they put the contrast up through the rectum and take x-rays, well, you are being exposed to radiation. We've all heard a lot about in the papers in regards to the radiation with our radiology tests. But even if you get that, you still should get a flexible sigmoidoscope because it doesn't catch the lower part of the rectum. Probably the best way, if you are truly average risk, is to get a colonoscopy. We can see polyps and we can remove them at the same time. So these are the fecal occult blood tests. You fish out that little piece of stool and you put it on your card, and then somebody will test it. And if they see blue, that's positive. If they just see that yellow, it's negative. You usually do a couple of the cards, 3 cards. Any one of them are positive, then you need a colonoscopy. And quite honestly, if you do hemoccult cards for 10 years, one of them will probably be positive. Probably not due to cancer, but pretty much you'll end up getting a colonoscopy. A flexible sigmoidoscope is just like a colonoscopy, except it only reaches up to this left part of the colon. It doesn't reach all the way over to here. Probably for the white male, it's reasonable to be screened that way. But for women and African Americans, our polyps tend to be on the right side, and so we probably really should get colonoscopies and not try to shortchange ourselves with just a short scope. But for the white male, getting a sigmoidoscope every 5 years is reasonable. If a polyp is found, they will be asked to go home, re-bowel prep, and come back and get a full scope. Again, complementing the two, maybe doing the fecal occult test and the sigmoidoscope will probably allow you not to miss anything. The barium enema, as you can see, there's a little tube that goes up with the balloon, contrast, and air goes in. You're completely awake for this. You get no sedation. You still have to bowel prep. Because you can't see because of this balloon, you should at least get a short scope to take a look at that rectal area. This should be performed every 5 years if you choose this. Now, a colonoscopy only has to be done every 10 years if you have no risk factors and no polyps are found. Again, it's a scope that looks throughout the whole colon. Granted, the worst part is the bowel prep, all right, and we'll talk about that. But if you see a little polyp like this, this can be removed. Here's another polyp. If you kind of see this, this looks like a little stalk with a little mushroom at the end. That's a polyp that can be removed. This is a nice, normal colon. That's what we want to see when we look inside. And you can see here this little ulcerated thing, that's a cancer. That's what we don't want to find. So leave that polyp in there anywhere from 5 to 10, 12 years, that will become a cancer. So we want to try to remove these before they start looking like this. And so here's a picture of a polyp, and this little stick actually had a little lasso that went around it. And so what we can do, we can literally lasso and snare that polyp, remove it, send to pathology, make sure there's no cancer in it, but it's also out of the body, so there's no risk of colorectal cancer, because this is what we don't want to have. Okay, so now you can see the difference. This is a cancer, before were polyps. So this is what a colonoscopy kind of looks like. Everyone's like, oh, I'm so embarrassed, I don't want a colonoscopy. Once the tube goes in, nobody's looking at your bottom, okay? Trust me. We're all looking at this monitor. The anesthetist is watching your airway, making sure you're breathing, getting enough oxygen. If you look like you're in a little discomfort, even before you feel it, they can redose you with more medication. The endoscopist and the nurse that's in the room, we're all looking at the monitor. The bowel prep is the worst part. There's no way to get around it. You're given things to drink, and it's going to make you go to the bathroom. My little trick I tell patients is buy some diaper rash ointment to protect your skin because you're wiping a lot. And don't buy Tux, don't buy those adult wipes, just buy some simple baby wipes. If they're safe and comfortable for a baby 10 times a day, then they're good for our adult bottoms also. And so once you're getting the colonoscopy, you're nicely sedated, you should not be aware of anything. Because a colonoscopy beats this, right? Being in the OR, having a colon resection done. And it is too common. Every time I'm operating on my 60 and 70-year-olds who have colorectal cancer, I ask them, was this your first scope? And many of them are saying, yes, that's my first scope. So for African Americans, there was in the New England Journal record now stating for African Americans that there should be a consideration to start at 45. It seems like their polyps start a little earlier, their cancers start a little earlier, and again, they're on that right side of the colon that the only way we can reach that is with a full colonoscopy. So you're not going to see this in the American Cancer Society recommendations or in the NCCN guidelines yet, but for my patients, I recommend it. Usually everybody has seen a little blood one day or another, and so there hasn't been a problem with insurances covering the colonoscopy at 45 for those individuals. And so what we're going to talk about is, while the lifetime risk is 6 out of 100 people will get colorectal cancer, you can see if you get one first-degree relative in your family that has colorectal cancer, your risk increases up to 2 to 3 times. If you have 2 first-degree relatives, 3 to 4 times. We're going to talk about these individuals who have a 60 to 85% chance of colorectal cancer, and these individuals, we call them FAP and AFAP, inevitably they're going to get colorectal cancer unless we do surgery on them. So what is Lynch syndrome? Lynch syndrome was first described back in 1895 when Dr. Worthen, who was a pathologist, who had a seamstress who was making his clothes, because that's how it was done in those days, and she just lamented and cried how she was going to die of cancer. She knew she was. This is her family. Every black dot, every black square is someone in her family who got colorectal cancer or endometrial cancer or gastric cancer. And she did end up dying of endometrial cancer. And it wasn't until Dr. Lynch came along, who in 1971 said, hey, that family looks a lot like my family I'm following in Nebraska. And so everybody at University of Michigan said, here, take all this information, and basically he made a career out of studying hereditary cancer. Now back when he was saying it's hereditary in the 70s, people said, you're crazy, it's all environmental. All these family members are all eating the same food, living in the same household, living in the same town, and that's why they're getting colorectal cancer. It has nothing to do with genetics. And for years, he was basically told he was crazy. But we do know that sporadic colorectal cancer occurs in the 60s. When I gave this talk just about 2 years ago, we thought the average age was 40s for Lynch syndrome. If someone is young with colorectal cancer, we have to think of Lynch. But we're finding that with our gene testing, we're now diagnosing more people with Lynch syndrome. And so just because they're older doesn't mean that they don't have Lynch syndrome. The Lynch syndrome patients have more than half of their cancers way over here. So again, if there is Lynch syndrome in the family, they have to get the colonoscopy, not the sigmoidoscope. And they have a very high risk, anywhere from 30 to 50%, that they're going to get a second colorectal cancer if they have one colorectal cancer. Much different than the sporadic colorectal cancers where only a quarter of them are on the right, and your chance of having a secondary cancer or a big polyp is only 16 out of 100. So again, the risk of getting colorectal cancer is much higher in the Lynch syndrome patient than in sporadic. Also, these polyps for sporadic cancer usually takes about 8 to 10 years for a polyp to turn into a cancer. That's why we get the colonoscopies about every 10 years. For families that have a strong family history, these polyps can transform within 2 to 3 years to cancer. Therefore, telling these people to wait 10 years for the next scope is the wrong answer. It's the wrong recommendation. Now, we do know with people with Lynch syndrome, we can interact with them, put them on a program, and prevent them from getting colorectal cancer. This is a study that was done in Finland. It was an observational study. They obviously didn't take 2 Lynch syndrome families and say, you're going to get a scope every year and you are not. But these were 2 families. One family that was very compliant, and compliant was being about every 2 years when they should have got yearly scopes. But you can see after 15 years, 92% of them were alive, did not have colorectal cancer. This was a family that was not so compliant and did not get their scopes, and you can see about a quarter of them in 15 years were dead of their colorectal cancers. Being diagnosed with Lynch syndrome, as I tell my patient, is not necessarily a bad thing. I mean, we know we can interact with you, we can do the yearly colonoscopies, we can prevent you from getting colorectal cancer. And it's interesting, even if they are diagnosed with their colorectal cancer, remember how we talked about those stages 1 through 4? They tend to be diagnosed more in stage 1 and stage 2. And also, if I take a patient with stage 2 with Lynch syndrome and take my other patient who got the sporadic colorectal cancer, that's stage 2, I know my Lynch syndrome patient has a much better chance of surviving their colorectal cancer. And the medical oncologists use this information, and frequently they do not even need chemotherapy after their surgery. So it's not necessarily a bad thing to have Lynch syndrome, even if you do get the colorectal cancer. The tricky thing is with these individuals is that they have a much higher risk of getting a secondary cancer. So the average Joe who gets colorectal cancer, their risk of getting a second cancer is pretty low. Maybe 4% chance, 5% chance they'll ever get a second cancer. My Lynch syndrome patients, they got about a 60% chance that they're going to get a second cancer, and it's not necessarily just colorectal cancer. So just like Dr. Worthen's seamstress who got uterine cancer, they have a high risk of uterine cancer. Ovarian is high, gastric, urinary tract such as the renal system, the small intestines, the gallbladder, and even brain cancer. And these kind of glandular cancers of the skin called sebaceous adenomas and sebaceous adenocarcinomas. People don't die from these, but it's a trigger that if I have a patient who has one of those, that I really start quizzing them about their family history in regards to the other cancers. So again, uterine cancer, the average person by the time of the age of 60, maybe 1.5 women out of 100 will get endometrial cancer. But if they carry the Lynch syndrome gene, 60 out of 100 will have endometrial cancer. So how many out there in the United States are walking around with Lynch syndrome? There's a mathematical calculation that we can do by knowing what is the population in America, what is the risk of colorectal cancer in the United States, and we'll even make it lower, say 5%. We'll say 3% of those have Lynch syndrome, but since only half the people actually present with their colorectal cancer, we have to times that by 2. There's 860,000 people in the United States walking around with this mutation, and I can guarantee you most of them don't even know it. That's 1 in 360 individuals. So we probably know somebody who has the mutation. Do the same calculation for North Carolina, taking the population. There's about 5,600 people surrounding the Wake County area that probably have this mutation, and most of them don't know it. So a little genetics that we're going to talk about. Try to make it very simplistic because I'm not a geneticist myself, but you know, you kind of think of your body as a library. And if you think about all these little chromosomes that are like the books, right? And on your chromosomes are all these little genes, kind of like the pages within the book. So the genes make up the chromosome, which makes up basically who you are. So all these little genes here, think of them like the pages in a book. They're little protein bases, that's all they are, that are very repetitive. And there are only 4 protein bases, but with all these nifty combinations, that's what makes us who we are. And so these protein bases, think of them as words on that page, which makes the chromosome into the book, which makes you the library. Okay, does that make sense, how that makes us up? So when we have our children, they get one of our genes. And if one of us had Lynch syndrome, and as we have a chance of giving that one bad gene off to one of our kids, that means they have a 50-50 chance they're going to inherit that gene from us. And that's how Lynch syndrome works. So if I have a mother with Lynch syndrome, her kids had a 50% chance that they got that bad chromosome from her. But they have a 50% chance they did not get that gene also. It's a little repetitive, I'm sorry. So with Lynch syndrome, this is how it works. You've got those little bases, those proteins. Our body likes to replicate in mirror image. The G's always lined up with the C's, the A's with the T's. But in these little areas of microsatellites, our body has a hard time in these stutter steps and makes basically a mistake. So if this is all normal, we get normal proteins in our body. But because of all that repetition, there's like a stutter step and then error occurs. Usually what happens is that then we get these abnormal proteins in our body. And these are proteins that are abnormal. Now they can't fight cancer. We have mutations in our body every day. But usually our body can repair those mutations. But for these individuals, their proteins are abnormal. They can't repair those mistakes. So these fixer genes are supposed to come in and fix this mistake. So our proteins and everything are normal. What happens with the Lynch syndrome patients, their little fixer genes are mutated, and therefore they get these abnormal proteins and can't fight off the cancer and mutations that then occur. So at Duke Hospital, every patient who is diagnosed with colorectal cancer gets testing done on their tumors for Lynch syndrome. So we can test the tumor before we even test the patient. And so we can look at it. It's not diagnostic, but it's kind of like a little screening test that we do. And so this is the test that kind of shows if those microsatellites are not normal in that individual. We can also do special stains. We can also do special stains on their tumor. Again, this is all done by the pathologist, where this is a nice normal stain. You see how it's a little darker in this polyp and tumor, but it's not staining here. It should stain there. It's not staining there. Again, when we get those reports, we think, wow, we got to really talk to this individual, see what their family history, probably get them to see a genetic counselor and talk about genetic testing and talk about them in regards to them and their family members a different interval of when they need to get their colonoscopies. So again, we look at their family history, and especially if we see someone with colorectal cancer or endometrial cancer, which is uterine cancer less than 50, that is a red flag to us. Or if they have multiple cancers. And so what I teach the residents is if they have a cougar cancer, okay? So if they have colorectal or ovarian or uterine or gastric, which is your stomach, or a renal cancer, and I've added the S to it for the skin cancers. If anybody has 2 of those cancers, they need to see a genetic counselor. If there's multiple generations of this, they should see a genetic counselor. Because usually sporadic cancer, it's, my grandfather had colorectal cancer at 82. Well, that's old, okay? And he's not near to me. He's a second-degree relative, not a first-degree relative. But when people come in and say, my mom had uterine cancer, her brother had colorectal cancer, my brother had a big polyp removed, you can see that's a different family history that we have to be concerned about. So well before we had gene testing, back in Dr. Lynch's day, all they had was to look at 3-2-1 rule. So if there were 3 relatives that had these cougar cancers in 2 generations and somebody was diagnosed in 50, they would say that this is potentially a Lynch syndrome patient. And so they would follow them as such. We've gotten better over the years. Now our pathologists can look at those slides like I told you to see if there's microsatellite instability. Look at all these different things in the slides, more than just the family history, to try to attune us to whether there's something familial going on. And so we know this is important to know because their first-degree relatives have that high chance of getting colorectal cancer. And a child of a Lynch mother or father has a 50% chance to have that mutation and therefore have that 60 to 80% chance of getting colorectal cancer. So it's nice to know when I have that mother in front of me with Lynch syndrome, can I tell her, yes, this child needs to get colonoscopies yearly, this one does not, and we do that with gene testing. Before anyone ever gets gene testing, which is now a blood draw, okay, everything we did in that, on those slides, were just on the tumor, not on the patient. When we do gene testing, this is on the patient. We draw their blood. They need to see a genetic counselor. And a genetic counselor will talk to them in regards to why to get gene testing, will your insurance cover it, they will check that, what are the pros and cons of gene testing, and that is a true informed consent, and that should be done. So they will talk to you about the accuracy of the testing. Cost is very important because some of these tests cost $3,000 to $4,000. Obviously, you want to know if your insurance can cover it. I can guarantee you your doctor won't know if it's covered, but the genetic counselor will. And then they can talk to you about some of the, there are some psychological stresses for some people that, they're going to feel like a bad parent if they have this mutation and transferred it to their kids. And so the genetic counselors are trained to deal with some of the anxiety that people may have. And also to talk about any concerns people might have about employment or insurance if they're found to have this mutation. GINA and HIPAA has helped us in regards to that. You cannot be discriminated from getting your health insurance because of a mutation. And with part of the Obamacare Act that has been passed, that has been strengthened and will be stronger in regards to making sure people are not denied getting new insurance, or if they lose their insurance, which it has happened in this economy, that's not going to be a pre-existing factor when they get their next insurance again with their new job. So the genetic counselor can go through all this within an individual. Now, currently most of this applies to group insurances. So if you're in a group plan at your company, that works out good. But truthfully, if you're, tends to be like the plumbers and the roofers who have individual insurance because they're self-employed, sometimes that may fall through the crack, but the Obamacare is filling in that crack. So the genetic counselor, when you meet someone, they're going to ask about your personal history, they're going to ask about your family history, and sometimes they'll ask if they can contact your other family members, may ask you to get the pathology report from from your mother or father who had the cancer. And then when the results come back, quite honestly, you can say, I don't want to know my results. That's a possibility. It's rare, but individuals do that. They have second thoughts about knowing about it. But you see the genetic counselor to review the results, to discuss what the results really mean. Because the results are not like a pregnancy test, okay? Just because there's no mutation detected, it may just mean that our technology is not good enough to find the mutation. You're still at high risk, so is your family. Only time we can truly say that someone is negative if, let's say, the mother has Lynch syndrome. I know her mutation. I test her son. He does not have that mutation. He is truly, truly negative. So it kind of takes one person in the family for the mutation to be known so it can really help the other family members. Once we find a mutation within an individual, then we test all the first-degree relatives. And so we know that the colorectal cancer can start younger, so therefore we start doing their colonoscopies in their 20s, and about every 2 years, and then after 40, it's yearly. Women, in regards to transvaginal ultrasound and endometrial aspirations, that has not been really shown to decrease their risk of cancer. They can do the screening if they want, but if they carry the mutation, probably as soon as they're done having children, they're probably better off getting a hysterectomy, which is a lot different than, remember all those things we went through with the people who have no family risk. So if there is a high tendency within the family, they need to be followed much more closely. These individuals wait until they're 50 to get a colonoscopy, or wait every 10 years to get a colonoscopy. They're probably going to get colorectal cancer. And again, we know if we screen with the colonoscopy, we will prevent colorectal cancer in these individuals. If it runs in the family, we can frequently tell them, might as well get an upper scope every 2 to 3 years. Make sure there's no gastric cancer. Checking for kidney and urinary tract cancer is just a urine test. That's very easy. You just urinate in a cup. It's not invasive. Again, the blood tests and ultrasounds and this, you can do it, but we haven't proven that to be effective as much as just getting a hysterectomy. So it's a little controversial. What do we do when a patient has colorectal cancer when they have Lynch syndrome? Do we just take a little portion of the colon out, or do we take out the whole colon? We do know that they have a 20 to 40% chance of getting a second cancer. And probably if they're diagnosed in their 20s and 30s, that probably is advisable. But if they're older and they promise they'll get their yearly colonoscopies, can probably still get away with just having a little section of the colon removed, because then you have to think about quality of life and how many bowel movements someone is having and things like that by taking out the whole colon. But I can tell you that there are a lot of people who are out there without a colon at all, and they're getting along quite nicely, having 2 to 4 bowel movements a day. And if a patient does decide to get their full colon out, we tend to keep the rectum. That still has to be looked at yearly, but it's a short scope. Remember that flexible sigmoidoscope? It's a very short scope, doesn't even require sedation, and the bowel prep is not as horrendous as a full colonoscopy. And then for the women, we talk about having a hysterectomy. So this is frequently what I hear from my patients. Your condition shows it's hereditary, and they say, good, send the bill to my parents. But, we do use some of that to help in regards to cost. Sometimes I'll get a father who says, I can't afford this genetic testing. If he has 6 sons and daughters who can chip in for the testing, that will help to defray the cost, they will do it because they got that 50% chance. If I can find the mutation in dad, now all the kids can get tested. Their testing is now 1/10 the cost because we don't test that whole gene. Now we test just a few sections of the gene, and then that makes a big difference knowing, yeah, I need a colonoscopy every year, or guess what? I didn't inherit that mutation. I can get a scope every 5 to 10 years now. Makes a big difference. So we do the gene testing because it does make a difference in cost. Sickle cell preps are done on every little baby, and that only costs us $236 to save one life. We do not have seatbelts in our school buses because it's $1.8 million to save one life. We do heart transplants all the time at Duke. We do breast cancer screening and pap smear screening all the time because the cost is anywhere from $30,000 to $150,000 per life year saved. That has been deemed reasonable in our society. Colorectal cancer screening, depending on which mode someone picks, colonoscopy or pap smears, is very cheap. It's only $10,000 to $25,000. To identify one person with Lynch syndrome, that cost is $73,000. Certainly more expensive than screening for the average sporadic colorectal cancer, but cheaper than the heart transplant money we spend on. But if we reach out to their first and second degree relatives, now the cost dramatically decreases as we interact. And that's what the whole Hereditary Cancer Center is about, is reaching out to beyond the patient that's in front of us. So this is a family tree, and this is how we look at families in the Hereditary Cancer Center. So the joke is women are perfect circles, okay, and the men are squares, okay? But that's just classically how it's always drawn up. So we can get a 26-year-old girl come in and says, you know, my mom had colorectal cancer, my father had colorectal cancer, his sister had colorectal cancer, and he had another sister with uterine cancer. And usually we get the story, and grandma died of something in the belly, we're not quite sure, but usually they can say if it's less than 50 or older than 50. And so she wants to know, is she at risk? She heard about Lynch syndrome. She goes, look, I got 3 families involved with these cancers. They span at least 2 generations, and a couple of them were less than 50. Do I have the cancer? Do I have that mutation? She has no symptoms. She's not involved. She's never been diagnosed with the cancer. So what we do, we say, we got to get your dad in. And we're going to look at his tumor and do those stains and guide us in regards to now doing gene testing. And if dad tests negative, we're still probably going to follow her as very high risk because, right, just because dad is negative, it may just be that our technology isn't there yet to find the mutation. But if dad tests positive, now this test that cost about $3,000, she can be tested for $250, $300. And most insurances will cover anywhere from 75 to 90% of the test. So for her, it may only be $20, $30 to be tested. And if she's positive, she knows she's getting that colonoscopy every 2 years and putting off having kids until she's done with her PhD or when she's done getting her MBA and she becomes vice president of the bank. She may decide she's going to have her kids now and get the hysterectomy done at a fairly young age. Whereas if her sisters test negative, they follow the regular colorectal screening guidelines. But see, this is what we do as a hereditary center. We say, you got an uncle out in Iowa. He needs to go see someone at one of the Iowa hereditary cancer clinics and be tested. And if he's negative, we stop there. If he's positive, now her cousins need to be evaluated. So if we just stopped here with dad, that's that $75,000 we, on the average, cost us to save one life. But reaching out to this whole family, this is how we get the costs much lower. So this was my very first family that I diagnosed with Lynch syndrome when I was at the University of Pittsburgh. And Ethel here came in with diverticulitis, and she was kind of hemming and hawing because she had to fill out her whole family history and says, why do I have to do all this? And so I start to explain to her about, at the University of Pittsburgh, I was in charge of the Hereditary program, and so I need to know what her risk was. And so she says, well, my husband died of colorectal cancer, and I think his dad died of colorectal cancer, and another brother died of something kidney related, and another one was diagnosed with something kidney related, but diagnosed at a young age at 35. And so then she asked me, so does that put me at risk? And I said, well, Ethel, unless your husband's your brother, you're good, because your family history is okay. But I said, what about your children? And she says, well, yeah, is my son at risk? And I said, yes, he is at risk. And so I said, do you have any daughters? And she goes, yes. And I said, your daughter's at risk also. And so down here is her son, and this is her daughter. Lo and behold, about 2 years later, her daughter shows up into my office with rectal bleeding. Kind of sounded hemorrhoidal, a little bit of blood on the toilet paper. And as I started talking to her, she said, oh, you met my mom a couple years ago. And I said, oh, you got this really strong family history. You're getting a full colonoscopy. I'm glad you came in. And we did. We found a very large polyp and removed it. She met Amsterdam criteria, but at that time, insurance would not cover for gene testing. She did not have cancer, and they just would not cover it. So I said, okay, Beth, you're coming back in a year for another colonoscopy. She didn't come back. She didn't come back the second year. We finally got her back on the third year, and she did have a cancer. But it was stage 1. So she bought an operation, but she did not need chemotherapy. She opted for the full colon resection because she realized I am not compliant. I hate the colonoscopy, so if you tell me I just have to do a couple enemas and get a short scope and I can go back to work in the afternoon, then take out my whole colon. Interesting, as we did her history, you know, Mom never told me about the other daughter who died at the age of 34 from uterine cancer. But Beth told me about her sister. And because I was telling her when I first met her about, you need to go to your gynecologist, you need to, you know, get your screening done. And she says, oh, I don't have a uterus. She goes, I got mine taken out as soon as my sister was diagnosed. I got her path report. She had a pre-malignant lesion, almost about to turn into uterine cancer. So Beth did all the right things back then, not even realizing why she was doing it. Finally, unfortunately, as she got diagnosed with her colorectal cancer, we did do gene testing on her. She has no children, but the whole reason we did the testing was that she has a niece and a nephew who, you know, are now turning 20, and now they can get gene testing because their mother has passed away, and so at least we can use the results from the aunt to see what their risk factors are. The other part of the family, there's no contact, they're deceased. The brother refuses to see a doctor, so we'll see what happens with him. So basically, we're blending the old with the new. Family history is good, all right, but we're using modern technology with the stains that our pathologists do, and also we're doing gene testing to do a better risk assessment. So like I tell all my residents, remember cougars, however way you want to remember your cougars, whether it's Demi Moore or a cougar, that's okay. But colon, ovarian, uterine, gastric, the renal cancers are a special type of cancer that are transitional cells or sebaceous tumors. Anybody less than 50 with the cougar cancer, anybody with 2 cougar cancers, multiple generation of the cougar cancers, anyone who's a first-degree relative to these individuals should undergo closer look by a genetic counselor and may need to start their colonoscopies at a younger age. Very quickly going through polyposis. Polyposis is a little bit more dramatic. I mean, this is what you get, a carpet full of polyps. This tends to be very, very obvious if someone has polyposis, though sometimes it's only a few. Again, these are autosomal dominant, so if somebody has adenomatous polyposis or attenuated, they got that 50-50 chance of sending it down to their family. And so someone with FAP probably has close to 50 polyps, anywhere to thousands by time I may see them for their surgery. If they don't have surgery, they will get colorectal cancer in their 30s. There's just so many polyps, one of them is going to transform into cancer. The attenuated FAP, they tend to have a few less polyps, maybe about 20 to 100. Don't do colonoscopies to diagnose them or a colon resection. They will eventually get colorectal cancer in 40s and 50s. Another one called MAP is kind of new. It spans the whole spectrum. And that one's a little confusing because it's autosomal recessive. So dad has the gene, mom has the gene, 25% chance that the kids will inherit both genes and then get the disease. So mom and dad are walking around not knowing they have the mutation because they don't have that increased risk of colorectal cancer. But because they both had the mutation and did not know it, they have that 25% chance that one of their kids are now going to have that disease. And so, again, knowing the history, for the FAP, those kids have to start with that short scope in their teenage years. And once they get so many polyps that they're hard to remove, then we talk about surgery with them. Those with attenuated FAP probably can wait till their late teen years with their colonoscopies. Again, once they have so many polyps that we can't remove them all through the scope, we talk about surgery. These people usually can save their rectum though, so they get kind of the similar operation as the Lynch syndrome patients. So this is a patient who had lots of polyps, and it's hard to see until you look very closely that here was her rectal cancer. Wasn't even picked up on a scope. So there was so many polyps you couldn't see the cancer. It's like when you're in an airplane and you're flying over a forest. There's a lake down in that forest, but you can't see it because the trees are covering it. And that's why we don't want people to get to this point of all these polyps, because we're not going to be able to catch that cancer. So here's someone who had an ileorectal anastomosis, and quite honestly, this is their scar. So next week, Dr. Hopkins is going to talk about minimally invasive surgery. This is one of my patients whose mother had FAP, died of her colorectal cancer at 38. He's a very smart kid, 16, 17. His mother had gene testing before she died. We knew the mutation. So therefore, her sister got tested, her children got tested. The boy tested positive. He had a scope. He already had about 100 polyps. And I said, you know, we could probably wait until you finish high school. And he's like, nope, I want my surgery. I want it now. And so we were able to do what's called a single incision surgery. And he has about, a scar like this. And through that, we were able to remove his whole colon. So just because people need big surgery, it doesn't mean that they have to look like it on the outside or actually feel like they had a big operation. And so we do all this now with fancy staplers that we can put the colon back together again. And so not necessarily people need the bags, the colostomies, the ileostomies that everybody hears about. It's not a common event we need to do. Even those people who have all the polyps throughout their whole colon and rectum, we can remove the whole colon and the rectum and hook up the small intestine to the anus so they don't have a permanent bag. They will have anywhere from 4 to 8 bowel movements a day. They might be taking Imodium, they might be taking fiber to thicken up their stools, but they don't necessarily need a permanent bag. And again, it's with all these little fancy staplers that we're able to connect things so low into the pelvis. But having a stoma is not all that bad. I mean, you don't want to wish it on anybody, but it's not a death sentence. Barbara Barry, as some of you may know from Suddenly Susan, or maybe back with Hal Holden, she played his wife, blanking on that show back in the 70s. But she's an actress, and she has a permanent colostomy due to rectal cancer. And so, you know, she's leading a very full life. So at Duke, there's lots of us that can help out with these things. This is our colorectal team. There's 5 of us. Dr. Wolf is a gastroenterologist who has very special interests in hereditary disorder. The head of our head of our hereditary cancer center here at Duke is Kelly Markham, who's a medical oncologist. And these are my pathologists I really rely on to do all the special stains. And Dr. Burchuk is a gynae oncologist. There's about 8 people in his group. I just couldn't fit them all on the slide. You can go to hhs.gov, and if you hit Create a Family Health History, you can make your own family tree. You just put in the information and it will draw all those circles and squares for you, and then you can take that into your family doctor or into your gastroenterologist and say, hey, this is my family, you know, do I need to do anything special? 2004, Thanksgiving was named National Family History Day. And that's because that's probably when we have the most of our family members around at one time, and we really need to share our family histories with each other, you know, to say, hey, I had a polyp last year with my colonoscopy. I hope my brother tells me if he has that, because that's going to be a difference on when I get my colonoscopies. So there are different types of colorectal cancers because there's different causes of it. And therefore that should be allowed to us to treat people very individually and very specifically. So a colorectal cancer is just not a garden variety colorectal cancer. So bottom line, don't smoke, okay? Try to keep your weight good. Exercise, eat right. Know your family history. Ask, share. Get a colonoscopy. If you have bleeding, you're anemic, your stool frequency is changing, the size of your stools are changing, you're losing weight, you don't know why, you have belly pain, you get it now, no matter what your age is. If you have no problems and you're African American, probably start at 45. If you have polyps found, depending on what type of polyp, how many polyps, the size of the polyp, you're going to need a repeat colonoscopy anywhere from 2 months to 10 years. So know the type of polyp when you get your colonoscopy. Ask your GI doctor how many polyps did you have. If you have Crohn's or ulcerative colitis, basically if there's full colonic inflammation, these people need to get yearly colonoscopies 8 to 12 years after diagnosis. If it's partial, definitely can wait till 12 years. But both of these individuals should get random biopsies. And so you need to make sure your GI doctor is doing that. The other site that you can go to is nccn.org. And with nccn.org, you'll see all these recommendations in when to get your colonoscopy done. Because let's face it, most of us don't meet Lynch syndrome criteria. But, you know, we may have grandpa who had colorectal cancer at 80, right? So start your colonoscopy at 50 and get it every 7 to 8 years. You may have a brother who gets a polyp at 50. So you get your colonoscopy at 50, or if your brother had a polyp at 40, you get your colonoscopy at 40 and every 7 to 8 years. So there's a lot of different guidelines out there. They're guidelines. The American Cancer Society has them. The Gastroenterology Society has them. The Colorectal Society has them. They're all a little different. But basically, if your family history is stronger, you need to start earlier. and you need to get your scopes a little bit more frequent. So I hope I made things clearer and not more confusing. And I want to put in a plug for my partner next week, Dr. Hopkins, who's going to talk a little bit more detail. Maybe he'll even have like a video so he can actually show you what an operation looks like when we do our minimally invasive surgery. And so I thank you for your attention and for you taking the time out.